So welcome to the second lesson on the TTKG. We're going to now talk about how to interpret the value that you get for the TTKG. Let's just put the formula back up on the screen. Actually, let's do it this way. Keep it consistent with the prior tutorial. This is one of the more common formulas that's used to determine how the kidney is handling potassium in the body. And we went over the contraindications for using the TTKG. We also talked about the parameters that have to be met in order for the TTKG to be accurate. And we talked about why other methods of measuring potassium excretion, namely the fractional excretion or the 24-hour urinary excretion, are somewhat suboptimal to this particular formula. So we also said that the range of TTKG can go anywhere from about 1 to greater than 10. So let's talk about TTKG values in the context of someone who's hyperkalemic. You want to know if a hyperkalemic patient has the ability to urinate potassium appropriately or not. If they do have the ability to urinate potassium appropriately, then you're looking for non-renal or extra-renal causes for the hyperkalemia. If the kidney is unable to eliminate the potassium correctly, then you know you've got a renal disorder in potassium excretion. So the TTKG will really help you determine if your focus needs to be on the kidney or needs to be outside of the kidney. You calculate the TTKG in a hyperkalemic patient and say you get a value that's greater than 6. A TTKG value greater than 6 in a patient who's hyperkalemic is what you would expect. It's what we call normal. The kidney is responding in the way that it's supposed to by excreting as much potassium as it can because of the elevated potassium in the serum. So when you have a hyperkalemic patient and their TTKG is 6 or higher, you know that you've got a problem that's extrarenal and not intrarenal. But say you get a TTKG that's less than 6. Now you know that there's something wrong in the kidney. There's a renal abnormality that's not allowing the kidney to excrete potassium effectively. And what that problem is, you don't know yet, but at least you know that your focus has to be on the kidney itself. Now you may have heard in your studies and on the wards that the TTKG is useful in determining if aldosterone activity is present or absent in a patient who's hyperkalemic. Now let's go through that one more time. Here's my rough animation of a glomerulus, and by now you may realize that I like drawing this picture over and over again, but it really helps solidify a lot of concepts. The area that we're focused on in terms of potassium management is here in the distal convoluted tubule and the upper part of the collecting duct, or the cortical collecting duct. And what we're looking at is where aldosterone is most active, and aldosterone is active in this region here. Aldosterone. We'll just limit that as aldo. So when you've got a TTKG that's less than 6 in a hyperkalemic patient, you know that not a lot of potassium is being secreted in this section of the nephron, and one of the main reasons could be that you have a deficiency in aldosterone. Now, the way to prove that is twofold. The first is that you can actually measure an aldo level in the serum to convince yourself that you don't have as much aldosterone as you should, you're hyperaldosterone, or you do a test here. There we go, stimulatory test. And that's what we're going to talk about on the next slide. Aldo level or stimulatory test. So let's clear this. Let's get our formula back up here again so we know what we're talking about. Okay, so that's our formula. And what we want to talk about is the stimulatory test. In this type of a patient, hyperkalemic patient with a low TTKG. So you know that if the TTKG is low, there's something wrong with the secretory capacity of the kidney as it relates to potassium. The kidney simply isn't secreting enough. The most common reason is that there's a lack of aldosterone. And the way to prove that is you administer an aldosterone agonist. And the most common one is fludrocortisone. There you go. Administer that. Wait about 4 hours. And then recalculate your TTKG. Now, upon recalculation of the TTKG, if you get a value that is greater than 6, you have aldosterone deficiency. You have a lot of evidence now for aldosterone deficiency. If you get a value that's still less than 6, you have one of two conditions. Either you have aldosterone resistance, or you don't have a problem with aldosterone activity in the kidney at all. You have some other problem in the distal convoluted tubule that does not allow potassium to be secreted. So this is a great formula to figure out whether you truly have a problem with aldosterone secretion, aldosterone's ability to cause secretion of potassium in the kidney or not. And using this stimulatory agent, you can then determine if you really have a deficiency in aldosterone or some other condition that requires further evaluation. Now let's look at another example of the TTKG. This is just the same old formula. Normalized for the amount of water that's absorbed in the distal nephron, which is where potassium secretion occurs. Now say you have a patient with a low serum potassium and you calculate a TTKG. And you get something that's less than 6 or greater than 6. Well, if you have a low potassium, your kidney, under normal circumstances, should not be excreting potassium. It should be holding on to potassium as best as it can. That would be represented by a low TTKG. So this would be normal or expected renal compensation. And of course the opposite is also true. If you have low serum potassium but your TTKG is high, you have renal losses. And you now need to focus your attention on what's happening in the kidney to cause potassium to be lost. For example, since we use the TTKG primarily to help us with aldosterone secretion, do we have elevated aldosterone activity? That's one possibility. Or do we have a defect in the remaining segments of the distal tubule that cause potassium to be leaked out or secreted rather easily? And so the TTKG also helps us in patients who are hypokalemic because it gives us a really quick distinction on whether we have something wrong with the kidney itself or something's happening outside of the kidney to cause the metabolic derangement. And there you have it. That's your TTKG and how it's used to assess the kidney's ability to handle potassium, and specifically the kidney's response to aldosterone, which is the main hormone that controls potassium secretion. Thank you very much.